because I'm not an obstetrician and I'm no expert on cesarean section, but I think he's been unable to join us this morning, and I've gotten some of his slides to share with all of you. These are my disclosures. So what I'd like to cover over the next 25 to 30 minutes is to talk about some of the concerns that we have seen with C-section rates and the health implications of C-section related dysbiosis as opposed to normal vaginal delivery. And then at the end, I'm going to talk a little bit about our consensus panel discussion and the results of those discussions. So you may be aware that the C-section rates globally have increased significantly. So in the 1990s, WHO was actually saying 10% or less. In 2023, so just 1 year ago, we have seen that rise 3 times to 21%. And the projected figures for 2030, I'm not sure whether you all can hazard a guess, but it's postulated to rise further to closer to 30%. So these are phenomenal numbers. So 1 in 3 babies would be born by cesarean section as opposed to normal vaginal delivery. So you can see that the C-section rates have doubled in the past 15 years and increasing on a year-on-year basis, and it's a worldwide phenomenon. So not just Western countries, but developed countries as well. Developing countries also increasing. And when we look at Southeast Asia, so India and Southeast Asia, our figures are not that much different, and each of our countries has seen a rise. So for example, in Singapore, we're looking at a 37% rate of C-section. So that's quite significant. And sometimes we ask ourselves, what are some of the reasons which are contributing to it? Of course, there would be medical reasons. So there are quite a number of medical reasons why babies are born by cesarean section, and some of these are really both life-saving for the mother and the infant, right? So because of abnormal position, fetal distress, cord prolapse. So these are life-saving for the infant. Sometimes for the mother's risk as well, if there's CPD or prolonged labor or other chronic medical conditions in the mother that make natural vaginal delivery difficult. So C-sections are medically indicated in quite a number of reasons. At the same time, I think there's been an increasing risk, or rather increasing prevalence of social reasons why some mothers prefer or have elective cesarean sections because they fear the pain of childbirth. They would say, I want to plan when the baby is born, right? Whether it is because of an auspicious date, for whatever reason, whether it's cultural or religious belief, they say, I want a baby born on a particular date, so they choose that date. Sometimes I've seen requests, or heard about requests because they want the baby born before the next academic school year, so that their kids don't end up being born on January the 2nd, they want them born on the 31st of December or January the 1st. So they want to make sure they get in time for the school year rather than miss a whole year. Sometimes it could be also because of negative experiences, or even nowadays because women are so busy and working, they want to pick a time where they can take leave conveniently, and therefore they want to choose the date of their child's delivery. So there are many what I call social reasons that these requests are being made. And we need to think about how can we then educate our patients or the mothers to say, hey, there are actually consequences of making this decision for your child. And therefore, what are some of these things we want to inform them about so that they can make a decision whether they really want to go ahead with the social reason for cesarean section as opposed to trial of normal vaginal delivery. Now, C-section has implications not just for the mother but as well as the offspring, right? So the mother has outcomes also. So I'll thank Dr. Rahman for this slide. There are good potential outcomes as well as negative consequences. As you can see, so it's a busy slide group, you can see some of the odds ratio. So in some cases it decreases their risk, in some cases it actually increases their risk of pelvic organ prolapse, fecal incontinence, subsequent subfertility. So there are risks to the mothers as well. There are also risks to subsequent pregnancy outcomes. So sometimes obstetricians will say, once a Caesar, always a Caesar. So first child born by cesarean section, they might be a bit reluctant to have trial of scar. So the second babies also born by cesarean section. If you have a third child, almost 100% that will be cesarean section as well. So there are consequences or implications to subsequent pregnancies that the mother has. And of course, there are significant concerns or implications to childhood outcomes. And I think our earlier speaker, Prof. Liver, also alluded to some of these things, right? And a lot of times you realize that these consequences are immune mediated. So whether it's eczema, asthma, wheezing, there are also metabolic concerns. So the more we know about the gut microbiota, the more we have seen it linked to outcomes which are what we call non-communicable. So obesity, type 2 diabetes, hypertension. So there are also implications outside of the immune system. And when we look at it, it's not just something that happens in another country, but it happens in countries that each of us lives in, right? So in Southeast Asia, we also have this increased data and information. So when we look at data about the increased odds of health consequences, we ask ourselves, are these studies of association, so just by chance they have it? Is there a causal implication? So do we see dysbiosis in children with asthma, eczema, atopy, inflammatory bowel disease? Or did the dysbiosis increase the risk of subsequent disease occurring? And is there a pathophysiological explanation for this? And I think this links really nicely with what Prof. Lever, the first speaker, has talked about, right? She talked quite a fair bit about the immune system, the gut microbiota, and things like that. So how is this linked? How is cesarean section dysbiosis linked to some of the mechanistic stuff that we heard about earlier? So this goes way back to what some of us might be familiar with, the Barker hypothesis or the hygiene hypothesis also, right? To say that early microbial exposure or agents in early life can actually protect against development of allergic disease. So this was an observation done quite a number of years ago in the 1980s, right? To say that, hey, if you had more children in the family, if you were living on a farm, the child had a lower risk of developing allergies. So why is that so? Why having more siblings living in an environment that was dirtier, more unhygienic, decreased your risk of allergies? And therefore the interest is early exposure to some of these things, did it actually shape or affect how your immune system develops, resulting in lifelong health implications, right? So these were observations that were done in the 1980s and that resulted in further study to what we understand today. And when we look at C-section and atopy, right? So children born by C-section have a definite higher risk of allergic rhinitis and food allergy. And if you see here, the odds ratios are 1.18, 1.23, 1.32. So it's definitely an increased odds of getting it. What is also really interesting is that the risk is higher in C-section babies without rupture of membranes versus rupture of membranes. So what this tells us is if you go for elective C-section, your risk is higher than if you actually had a trial of delivery, and then emergency C-section, right? So it also tells us to say that emergency C-section after having attempt at vaginal delivery obviously must have resulted in some microbial transfer during the time of labor. And that tells us, okay, so if patients are willing for at least an attempt before saying, I want to go for elective C-section, those who have emergency C-section because they couldn't help it actually are less worse off compared to those who just purely go for elective C-section. There's also a higher risk of food allergies, and not unexpected. If the mom has food allergies, infant is also at much higher risk of food allergies. And what I think studies have demonstrated and shown that infants born by C-section have an altered microbiota. And it's probably this imbalance between the Th1 and Th2. So Prof. Lever mentioned, right? There's a Th1, Th2 balance, and the infant's immune system needs to learn something new. So pictorially, this is how I look at it, right? So in utero, it's really a Th2 system because it has to be tolerant, right? The mom is not going to reject the fetus. So the immune system in utero is one of tolerance. So accept me, right? Accept the baby. But after delivery, the body's immune system needs to learn, right? Prof. said, needs to learn how to protect the infant against pathogens. So somehow there must be that shift from I tolerate, right? I have tolerance, and now I need to actually be able to defend the fetus or the infant against bacterial pathogens. So there is actually this shift of what I call a balance between going from tolerance to infection. And somehow the human body or the immune system is so smart to say that I still need to be able to tolerate things even after delivery, right? So oral tolerance, right? Food that you ingest or you eat, you want to be able to tolerate and not mount an immune system reaction to them, right? That's why maybe food allergies, increased risk of food allergies. But at the same time, if I have a pathogen entering my GI tract, I need to actually recognize that as a pathogen and not accept it as okay. Okay, so how does this balance occur, and is there really that window of opportunity? And the early studies would suggest that being exposed to bugs must do some magical thing to the immune system such that in future you're actually different from somebody who didn't experience that early life influences as you did. And Prof. Livia did mention about the gut-associated lymphoid tissue, the GALT, because our immune system, our human gut is full of immune cells. The bulk of our immune cells actually reside in the gut. And really it's the contents that the gut is exposed to in the first few weeks or months of life that actually shape how the lymphoid tissue works, right? So whether it's the milk that the baby is drinking, so breast milk, and that's why breast milk is so full of immune cells and constituents that actually will affect the immune system, as well as your gut microbiota. So we heard about the crosstalk that's occurring between all these various factors and how it's important and how it develops, right? So babies, the current belief is that babies are born, or rather are sterile. So in utero is a sterile environment. And there are actually 4 or 5 phases as they go through in terms of acquiring the microbiota and how the microbiota is acquired, and whatever happens to the baby in the first few months of life will determine how the microbiota is shaped, right? So the first week of life, how the baby was born, early liquid feeding, so whether it's breast milk or formula feeding, when the baby starts eating solids, so that's the next point whereby you can train or expose the gut or the immune system to new antigens and new mechanisms for shaping tolerance or immunity. And then subsequent phase 5 is between the ages of 1 to 3. And our current understanding is that the gut microbiota does evolve until the age of 3 to 6 years, and beyond 6 years of age, it's relatively stable. What this means is that if you try and change somebody's microbiota at age 8 or 9, or even as an adult, you take a probiotic, and your stool microbiota would change while you're taking the probiotic. But when you stop taking the probiotic, it will revert back to what it was prior to that. That means you cannot make a permanent change to your gut microbiota after a certain age. So when you think about it from 3 key time points in the first year or first 6 months of life, really the first determinant is your mom's gut microbiome. What's a microbiome like in pregnancy? Because you actually acquire, the baby will acquire maternal microbiota. The second thing, of course, is the delivery mode, whether it's vaginal delivery or cesarean section. And of course, the third determinant is what you are feeding the infant in the first few months of life. And if you look at it pictorially, then really in pregnancy, those would be for potential points of intervention, right? So what's mom's gut microbiota like? What's a vaginal microbiota like? What determines that? The diet, life. We also know that stress can actually shape gut microbiota. And there's really, really interesting studies looking at maternal stress in pregnancy changing fetal and infant brain, right? So MRI studies of infants' brains are different if the mom was stressed in pregnancy. So how did that happen? What actually caused that to happen? Maternal exposure to antibiotics, because we know antibiotics will change your gut microbiota, and other immunological interventions to mom. So if mom had a chronic medical condition, that will also change her gut microbiota. We alluded to, of course, the main things at delivery with cesarean section versus vaginal delivery. Gestational age at birth, so premature infants have a slightly different gut microbiota compared to term infants. And one of the things which is also very important, if I think, if I'm not mistaken, almost all cesarean sections, mothers are given antibiotics, right? So not only is it your mode of delivery is different, you got double whammy, another dose of antibiotics given to mom at the time of C-section. So there are a lot of things, in these 3 broad time points that can actually affect an infant's gut microbiome. So they're also important or potential time points for intervention, right? So you could negatively impact it, but at the same time you can say, hey, what can I do to not negatively impact the baby's gut microbiome? So back again to the mode of delivery. So generally, if the baby is born by vaginal delivery, the infant gut is colonized by maternal vaginal microbes. So specifically the bifidobacterial species and the Bacteroides species. And many studies have shown a lower risk of immune-mediated conditions, as opposed to cesarean section, whereby you are then colonized, babies colonized more with skin microbes, as well as hospital microbes or bacteria. So they have a lower abundance of bifidobacterium and a lack of Bacteroides species. We call this gut dysbiosis, and then the consequence is a much higher risk of immune-mediated conditions. So there have been quite a number of studies that have shown this difference in the gut microbiome. You can see that over time, so this graph looks at pictorially the type of microbes in the stool. And you can see that 4 days, 7 days, 21 days, and later on, it does change. It does change, right? So even with babies born by C-section, you do see that the pattern or the types of microbes actually does change. And maybe by the time you look at it beyond 21 days, it looks maybe similar, a bit closer to that of the infant who was born vaginally. So the human body will try and say, can I get back to normality, especially in babies who are breastfed, right? You try to normalize your gut microbiota. But the first 2 to 3 weeks, they are different. And I will share with you a bit later that this difference actually is potentially significant. Again, meta-analysis or systematic reviews of stool of infants suggest that, from birth to 7 days or even later from 8 to 30 days. So the first month of life, definitely much less bifidobacterium in infants born by C-section. And this is really important because you know that bifidobacteria are the main colonizers of the infant's gut. And this is significantly different if they're born by C-section. So this is a very nice study looking at the different days from birth by infants born by caesarean section versus those born by vaginal delivery. And these infants were mixed fed, so they were breastfed as well as formula fed. And you can see from this graph that for those who are born by vaginal birth, straight away the bifidobacterial count goes up really within the first 2 weeks and it's very stable. Those born by C-section who are breastfed and formula fed, so mixed feeding, it actually goes towards what a vaginal delivered infant's bifidobacterial count is, but it takes up to about 16 weeks before you achieve similar bacterial counts for the bifidobacteria. So it actually, with breastfeeding, caesarean section babies actually do normalize in that sense the pattern of bifidobacterium colonization. But what is really interesting is this study done by Gusto in Singapore is an observational study, so it's not interventional. They looked at infants with eczema and without eczema at 18 months, right? So they had infants who were 18 months old with and without eczema. And the power of this cohort study was they actually collected stool from the babies at birth and at several time points in the first year of life, right? So they didn't know that these babies were going to get eczema or not, right? Because when they collected the stool, they just collected stool from every single child. And what they found really was that in children without eczema at 18 months, their gut was colonized early on with Bacteroides or B. fragilis, very much less E. coli and Klebsiella. And later on, after 3 months of age, the bacteria that was found were those who were butyrate and propionate producing, so short-chain fatty acids. And this is very important, short-chain fatty acids, that's how they actually help with a variety of immune system functioning within your infant gut. And when they look at infants who had eczema at age 18 months, when they look at their gut microbiota at 3 months and 6 months a bit later, it was actually different. Right, it was actually different. So as early as 3 months, the gut microbiota was different in infants who subsequently had eczema versus those who didn't. So it just tells us that even though later on you might normalize your gut microbiota for whatever intervention, if you've missed that early window, you really missed the boat in changing the potential outcome for the child. So it's not surprising that when we look at C-section and normal versus normal vaginal delivery, higher chance of allergic disease, higher chance of type 1 diabetes, higher chance of obesity. And if you look at just early antibiotic use, so I mentioned, right, C-section and antibiotics kind of go together. But if you look at children who had early antibiotics, even if they were not born by C-section, just the mere use of antibiotics in your first year of life, you actually have a higher chance of immune-mediated conditions as well as asthma, diabetes, and obesity as well. So antibiotics alone confers that increased risk to infants as well. And the studies do suggest that the number of bifidobacteria in your intestinal microbiome may take up to 6 months to normalize or become similar to those of normal vaginally delivered infants. But even if they became like a normal vaginal delivered infant, their risk is still increased, right? So that early first few 3 to 6 months actually does make a difference. So then what are some of the interventions available for us to correct this dysbiosis, right? So if it's already happened, so as I mentioned, sometimes C-section is medically indicated and we need to, for the mother's sake or baby's sake, do a C-section. So if we cannot avoid it, then are there options to actually limit, minimize, prevent further dysbiosis from occurring? So if you think about it, there's probably 3 or 4 broad ways of doing it, and people have tried a variety of ways. So one is vaginal seeding or vaginal microbiota transplant. So they've taken mother's vaginal microbiota and smeared on the infant, right? So this has been demonstrated to work. There are some downsides to this because not only would you get the good bacteria, you might get unintended pathogens as well. You could actually do FMT directly. That means give the baby directly microbiota from mother or other sources, right? So that's also, again, risk of harmful bacteria. Or you can actually use nutritional intervention, which would either be a combination of prebiotics, probiotics, or symbiotics. So Prof. Flavio mentioned the different types of biotics that can be used. And I'm not going to talk too much about this because I think the next talk will focus largely on intervention strategies. However, I do want to just share the results of one study. So this was a study conducted in Singapore and Thailand. I'm not sure whether any of the people in the audience here were actually collaborators on this particular study. It was a randomized control trial looking at C-section delivered infants, and they were randomized to 1 of 3 formulas. So one was a standard cow's milk formula, so that was a control. One that was prebiotic supplemented, one was symbiotic supplemented. And then there was a non-randomized normal vaginal delivery reference group. All infants were mixed fed, so they were given the formula and breastfeeding was encouraged and allowed. So they were breastfed as well as formula-fed infants, and the study was until 16 weeks. As you can see from this graph, so again, the reference group, vaginal delivered infants, was this black line. And C-section delivered births were given the symbiotic formula. Looks like they're actually very similar to the reference vaginal delivered infants. Whereas when you look at the C-section infants who were given the standard formula and C-section infants who were fed the prebiotic formula, their colonization was actually similar. So it does suggest that if you just give a prebiotic without extra probiotics added, you don't actually have the ideal type of colonization for infant gut. So that's the only slide I'm going to sort of mention because it's just food for thought prior to the next speaker coming on. The last few minutes, I'd like to just share some of the discussions that we had as a group of clinicians thinking about this really important topic about C-section, the fact that dysbiosis has been described and will occur after C-section delivery, and what can we do to restore gut microbiota. Part of it was also discussion about education because we need to educate obstetricians, primary care, healthcare professionals, as well as patients, right? Because what we want to do is prevention rather than cure, right? So there's a whole group of mothers who are opting for elective cesarean section. How do we get the message out there to say that don't do this purely for social reasons? So the 11 experts from India and Southeast Asia comprised of peds, allergy, gastro, nutrition, pediatricians interested in these areas, as well as 5 obstetricians and gynecologists. And we came from quite a number of countries in the region, so Cambodia, India, Thailand, Malaysia, Singapore, and Vietnam. And then what we did was we kind of met a number of times from the end of last year. We had a number of questions that we surveyed the group. We had a consensus meeting virtually in March, and then we actually met in May to sort of brainstorm and talk further about this. And we do hope to have a manuscript in print or submit a manuscript, and hopefully that will be accepted. The 4 broad areas we talked about, so we discussed and had questions around the 4 areas that you see here. We discussed the importance of early gut microbiome establishment. What were some of the key health implications associated with C-section dysbiosis? What are some of the strategies to address this and the different types of biotics that are available based on current studies and interventions to restore this and to debate between the various options. So we did a systematic search of the literature and we came up with 12 consensus statements, and basically we sort of voted on those statements. And in terms of consensus, if 75% of us agreed with a particular statement that we said, we reached consensus, it was high level consensus. When less than 55% of us, so just over half of us said we didn't quite agree or we're not in agreement with those statements, then we felt that it was low consensus statement. So this is how we came up with our 12 statements. And I'll just share with you some of the key things. So uniformly or universally, all of us decided that the mode of delivery will impact the composition of an infant's gut microbiome. And I trust that after you've heard about all the stuff I've said, you would also tend to agree, or you will agree wholeheartedly that there's enough evidence to suggest that this occurs. 82% of us felt that infants delivered by C-section exhibited a gut microbiota that was markedly different from those born vaginally and potentially increasing the risk of subsequent future health complications. All of us agreed that bifidobacterium was a crucial group in the early stages of intestinal development. 91% of us felt that there was a critical period in development where the immune system is shaped by microbial influences. This was where we had a bit more debate in terms of when was the most optimal window, right? Is it 3 weeks, 3 months, 1 month, 6 months? We do know that the infant gut microbiome is sort of can be shaped up until somewhere between 3 to 6 years of life. But is there that window whereby we want to actually try and normalize it because we know the immune system is actually developing, right? The Th1, Th2, allergy, immunology is all developing. Is there that window we also don't want to miss? This was where we couldn't get quite consensus whether it was 3 months, 4 months, 5 months, 6 months, and whether there's actually enough data or more data in future to help us be clearer about when that is. And all of us agreed that there were long-term health implications in terms of increasing risk of asthma and obesity. The next few statements were really about intervention, and I probably don't want to go through this because you all haven't seen the evidence yourself, and I would like the next speaker to actually go through his slides before I share this with you, so I'm going to just skip that. The take-home message is early life gut microbiota does impact health in later life, right? So that's a key message. The early gut microbiota development of a child will impact health in later life. So that's the main thing I hope all of you will take away from today's or this morning's sessions. And really the gut microbiome will develop based on influences from pregnancy, from birth, infancy and childhood. There are positive things that will promote or shape eubiosis or good gut development. And there are things that can happen that will be detrimental and result in dysbiosis, right? So there's plus factors that we can work on, and there are minus things we should try to minimize. And really what the things we're discussing today is at or around the time of delivery, the mode of delivery does impact this. And where possible, we would always want to do whatever is natural and what would give our infants the best possible start in life. So thank you very much, and I will turn it back.
Thank you so much, Prof. and Maren.